Welcome dear students, I am Dr. Pratyusha and in this video let us learn about the diseases of tympanic membrane. We have already learnt about the anatomy of tympanic membrane. Let me quickly revise it for you before learning the diseases. The tympanic membrane separates the external ear from the middle ear. It is divided into two parts, pars tensa and pars flaccida, also known as shrapnel's membrane. The major landmarks on the tympanic membrane are the cone of light, umbo and the handle of malleus. And you also have two folds called as the anterior and posterior malleolar folds between the pars tensa and the pars flaccida. And also there is an annular ligament encircling the tympanic membrane. This is very briefly about the anatomy before we study the diseases of tympanic membrane. So let us move into our topic. And when I say diseases of tympanic membrane, what is the first thing that comes into your mind? The first and the most common disorder I can say? It is the perforated tympanic membrane, perforation of tympanic membrane that we commonly see in our clinics. So first let us study about perforation of tympanic membrane. Perforations of tympanic membrane can be categorized into various types depending upon the location and the size of perforation. Size of perforation is very simple. It is a small perforation or a medium perforation or a subtotal perforation or a total perforation. It's very easy to understand. But we have to learn about a central perforation and a marginal perforation properly. Central perforation is that which is involving the pars tensa without involving the margin, and that is a safe type of perforation. So the categories are, first one is a central perforation, and then we have marginal perforation, and then attic perforation involves the pars flaccida part of tympanic membrane. Now please understand that marginal and attic type of perforations are unsafe type of perforations. So now the central perforation, depending upon the size, it is grouped into a small perforation or a medium perforation, subtotal or total. Small means involves only one quadrant. Now the pars tensa part of tympanic membrane can be divided into four quadrants as you all know: antero-superior, antero-inferior, posterior-superior and posterior-inferior. Now if the perforation involves only one quadrant, I can call it small. Medium involves two quadrants. Subtotal is more than two quadrants. And a total perforation means, and a total perforation means where the entire tympanic membrane is perforated. There is an open view into the middle ear. Even the annulus is not properly seen. That is a total perforation. I will show you pictures of these perforations for better understanding. This, as you can see here, is a small perforation involving only a single quadrant, and this is a medium perforation involving two quadrants, and I can show you an image, and this is an image of a subtotal perforation where more than two quadrants are involved. And total perforation is where the entire tympanic membrane is perforated. And next let us move on to marginal perforation. A marginal perforation usually involves the posterior-superior quadrant. And the characteristic feature of marginal perforation is that the margin, the bony annulus, is also affected, eroded. Bony annulus is also involved in the perforation. Please look at a picture of marginal perforation where you can see here that the perforation is beyond the normal margin of the tympanic membrane. That is a marginal perforation. Then, the last type of perforation is called as attic perforation, and this is a perforation in the pars flaccida region of tympanic membrane. And this perforation is usually a result of prolonged retraction. An attic perforation occurs because of prolonged retraction pocket that is formed in the pars flaccida, and slowly it will lead to a perforation. But the most important point is it is in the pars flaccida region, and it is a result of prolonged retraction pocket. Retraction in the sense the tympanic membrane is invaginating into the middle ear space. We will eventually learn about retraction of tympanic membrane also, but for now, please remember that an attic perforation is a result of prolonged retraction pocket of the tympanic membrane in the pars flaccida region. So let me show you a picture of attic perforation also. This is a picture showing attic type of perforation involving the pars flaccida region. Now, an attic perforation is usually very small in size, but please remember that it is an unsafe type of perforation. So, these are the various types of perforations in the tympanic membrane. Now, based on the etiology, let us look into what is a traumatic perforation of tympanic membrane. Traumatic perforation. Even while studying about the external auditory canal diseases, we have studied various instances where trauma to the ear can result in various diseases. Now, let us look at traumatic perforation in detail. In traumatic perforation, the first and the most common variety is because of a Q-tip injury. Now, I am putting them all under Q-tip injury, but there are various instruments that will result in perforation of the tympanic membrane, that will result in trauma to the ear using earbuds, using hairpins, matchsticks, needles. There are so many things that are put into the ear. This can happen in pediatric age group and also in adult age group in case of itching of the ear. So, to scratch the ear, various substances are put into the ear, and another possibility is even unskilled instrumentation, that is an iatrogenic cause of perforated tympanic membrane. Unskilled instrumentation that is done while cleaning the ear or to remove an impacted foreign body can also result in a traumatic perforation. All these can come under the category of Q-tip injury. Second in this category is air pressure. Air pressure can also lead to perforation. For example, while doing a forceful Valsalva maneuver, and in case of bomb blasts which produce more than 200 decibel sound pressure, and also while traveling in an aircraft that is not pressure adjusted properly. All these results can, all these causes can result in an increased pressure in the middle ear, which will finally perforate the tympanic membrane. Then, we also have fluid pressure. Water or any other fluid going into the ear, which can happen very much during diving or during water sports if the ears are not properly protected. And also during forceful syringing or foreign body removal also, the pressure of the fluid can be very high and it can perforate the tympanic membrane. Now this type of perforation will immediately lead to an infection also, because water usually carries many organisms, and when along with the perforation, all this water, contaminated water, also enters the middle ear and causes middle ear infection. And in the final variety we have traumatic type. Now when I say traumatic, I am not talking about the matchstick or the Q-tip injuries. It is head injury or some fracture of tympanic bone that, it is some head injury or fracture of the temporal bone that can also result in a tympanic membrane perforation. Under traumatic heading, I mean bigger and serious causes such as head injuries or fractures of temporal bone. All these things can result in traumatic perforation of tympanic membrane. Now let us look at the clinical features of a perforated type of tympanic membrane. What happens if the tympanic membrane is perforated? First, symptomatology. The patient will present with the complaints of hearing loss. And that hearing loss is conductive type of hearing loss, because the tympanic membrane is a part of the conductive apparatus of hearing. So, patient first complains of hearing loss, and this hearing loss is sudden. And this hearing loss is sudden. It is sudden from the moment the tympanic membrane has been ruptured or perforated, and also it is conductive type. Next, ear pain is one common complaint. Otology will be there when the tympanic membrane is perforated. And we also see some discharge from the ear, otorrhea. Now this otorrhea can be blood stained if it is a traumatic type of perforation, or it could also be purulent or mucopurulent or mucoid if it is a result of otitis media. Okay. And then certain other uncommon presentations are tinnitus and vertigo. These are usually seen when there is head trauma or some other traumatic incident that has happened. Now these are usually seen when there is a head injury accompanying tympanic membrane perforation. Upon examination, what we find is, with the otoscope, you can clearly appreciate a perforation in the tympanic membrane. But if it is a traumatic perforation, even the external auditory canal could be damaged, even the external auditory canal could be injured, and sometimes that can obscure your way and do not let the tympanic membrane to be visible. Now the first clinical sign that we see is perforation of the tympanic membrane. And we should immediately assess what type of perforation is it. Is it central or marginal or attic type? And if it is central, what is the size of the perforation? Because all these will decide the prognosis of the perforation, whether it will heal or not. Okay. And then if it is a large perforation, and when we look at the perforation, we should try to assess the type of perforation, the size of perforation, and also the margins of the perforation, whether they are regular or irregular type. If it is a traumatic perforation, you can also see bleeding and other injuries of external auditory canal and other surrounding structures. These are the two classical things that we see on examination. And when we do tuning fork tests, they show conductive type of hearing loss. Even audiometry would show conductive type of hearing loss. And the amount of hearing loss depends upon the size of perforation. And you will also see that all other landmarks, and you will also see that all other landmarks of tympanic membrane are disrupted. The cone of light is definitely disrupted or disturbed even with a small perforation. And depending upon the size, other landmarks could also be distorted. Now, what is the treatment of a perforated tympanic membrane? Initially, we go for conservative type of management. That is, if it is because of some infection, we would prescribe antibiotics and anti-inflammatory drugs along with analgesics. And most important is to advise the patient to keep the ear dry. At any cost, he should not allow further infection, because now the tympanic membrane is open and anything that is put into the external auditory canal will directly reach the middle ear and cause potential infections to the middle ear and other sensitive structures present there. So, keeping the ear dry is of utmost importance, and installation of any ear drops should also be avoided so that dirt and other infections are not sent, so that dirt and other infections do not reach the middle ear. If it is a traumatic type of perforation, the external auditory canal on the affected side has to be dressed with a cotton ball. Okay, dressing of the wound has to be done in case of a traumatic perforation. Dressing of wound. Now let us look into the complications that can arise from a perforated tympanic membrane. First, as I have already discussed, is transmission of infections into the middle ear. Infections become more and more common and frequent with a perforated tympanic membrane. Then, facial paralysis can occur because the facial nerve is now exposed to the external environment. And then subluxation of stapes can occur. Sensory neural hearing loss can also occur later on because of repeated infections, and if in case if it is a traumatic perforation, the trauma can go as deep as to the inner ear also. Then sensory neural hearing loss can occur. And in some circumstances, vertigo and nystagmus can also occur. Vertigo and nystagmus. So these are the various complications that can occur as a result of perforated tympanic membrane. More so in case of a traumatic perforation, because we do not know how deep the injury has gone. A trauma can involve only the external auditory canal, or it can perforate the tympanic membrane, or it can go very much deep up to the inner ear also. Okay, so this is about the first disorder of tympanic membrane. Let us move to the next one, and that is Tympanosclerosis. Tympanosclerosis means hyaline degeneration or calcification of the fibrous layer of tympanic membrane. Now we know that there are three layers in the tympanic membrane: outer epithelial layer, middle fibrous layer, and inner mucosal layer. Now in this fibrous layer, the middle layer, it can undergo calcification or hyaline degeneration, and that is called as tympanosclerosis. Calcification or hyaline degeneration of the fibrous layer. Okay, And this can occur due to a connective tissue disorder. It can occur because of a connective tissue disorder, and it can also occur in serous otitis media, a patient who had a removed grommet as a complication. And this tympanosclerotic plaque can also be found in the middle ear. It can extend into the middle ear and also the mastoid antrum. It can involve the ligaments, the ossicles, muscle tendons, and also the submucosal layers of middle ear cleft. So tympanosclerosis is not just a disorder of tympanic membrane, it can go very much into the middle ear and cause problems. Now, after understanding what is tympanosclerosis, let us look into the clinical features of tympanosclerosis. So first thing, when we examine the ear, what we find is chalky white plaques. There will be chalky white plaques on the tympanic membrane. But the patient is usually asymptomatic, okay? So there are no complaints from the side of the patient. Mostly what you find are signs. There could be reduced hearing. Hearing loss is possible. And if at all hearing loss is present, it is of the conductive type of hearing loss. And tinnitus could also be seen. Ringing sensation in the ear is seen. Next, coming to the diagnosis of tympanosclerosis, it is usually a clinical diagnosis. When we examine the external ear, when we do an otoscope, we find these chalky white plaques on the tympanic membrane, and that itself makes the diagnosis of tympanic membrane. A pneumatic otoscopy, if done, that can demonstrate the mobility of tympanic membrane also, if at all the mobility is affected. These plaques are usually firm and they are contained within the middle layer of the eardrum, that is the fibrous layer of the tympanic membrane. Now, unlike cholesteatomas are soft and they are present in the middle ear. Tympanosclerotic plaques are firm and they are limited to the fibrous layer of tympanic membrane. They can also extend into the middle ear, but they are initially seen in the fibrous layer of tympanic membrane. So, diagnosis is usually clinical with an otoscopy. Now, let us see how tympanosclerosis can be treated. Now, first of all, does it require treatment? If at all the plaques are very small and if they are not interfering with the mobility of the tympanic membrane, you can just leave them as they are. No need of any treatment. Because if you try to remove the plaque, it will lead to a perforation of the tympanic membrane, because as I said, the plaques are firm and removing the plaque can cause more harm than the plaque itself. So, if they are not symptomatic, not affecting the mobility, do not treat a tympanosclerotic plaque because it can cause a large perforation of the tympanic membrane. If at all, if it is causing hearing loss, affecting the mobility of tympanic membrane, then we can go for a myringoplasty to remove the plaque. Now, that will create a perforation and you should also repair the perforation with a graft. So, first is asymptomatic patient, no treatment. If mobility of tympanic membrane is affected, then we have to go for a myringoplasty. Myringoplasty is the surgery wherein you will remove the plaque and put a graft in the perforation. But now, if the plaque is large and there are no other complaints, only hearing loss is present, then hearing aids are suggested without going for a surgery. Okay, hearing aids can be prescribed if at all the patient is having hearing loss. So, hearing aids are preferred more than myringoplasty also, if at all hearing is the only problem. Alright. So, this is about tympanosclerosis. The next disorder in our list is atrophic tympanic membrane. What is an atrophic tympanic membrane? A normal tympanic membrane has 3 layers. If at all the middle fibrous layer is absent or it is damaged and destroyed, then we call it an atrophic type of tympanic membrane. This can happen in serous otitis media where the eustachian tube is not functioning properly. In eustachian tube insufficiency, what happens is the middle fibrous layer gets absorbed, and when the fibrous layer is absorbed, the tympanic membrane becomes thin and it can easily collapse. Now, perforations of tympanic membrane which heal, even in a healed tympanic membrane, the fibrous layer is missing. And this makes the tympanic membrane thin and more susceptible to further perforations. Because regeneration of the tympanic membrane perforation, the healing is only by the outer epithelial layer and the inner mucosal layer, but the in-between fibrous layer will is missing. So, the original strength of the tympanic membrane is never restored in case of a perforation, or if at all the fibrous membrane is absorbed, as in a case of serous otitis media. So, that is about atrophic tympanic membrane. The main feature is the middle fibrous layer is damaged. Either in case of serous otitis media where it is absorbed, or a healed perforation. Let us now move into the next disorder, and that is Myringitis bullosa. Myringitis bullosa is also called as bullous myringitis. This is an infectious condition where you see blisters or bullae or vesicles on the tympanic membrane. Not just the tympanic membrane, the bony part of external auditory canal also. The name itself is explanatory. Bullous myringitis, you will find bullae. Not just bullae, we can also see vesicles and blisters. And vesicles are found not just on the tympanic membrane but also on the deeper part of external auditory canal. It is an infective condition. This occurs as a result of infection. And the clinical features are, first, there is sudden onset of pain. As it is an infectious condition, pain will be there. There is sudden onset of pain, and this pain is severe and also it is seasonal. And then oral fullness is felt by the patient. The patient feels fullness of the ears. We can also see some discharge coming from the ear. And what is the nature of the discharge? It is non-foul smelling but blood stained. This is the type of discharge, and also there is mild conductive type of hearing loss. When we examine, we will find blisters or bullae, and these are filled with serosanguinous and hemorrhagic fluid on the tympanic membrane or on the deep part of external auditory canal. On examination, what we see is bullae and vesicles, with serous or hemorrhagic fluid. This is about bullous myringitis, and treatment for bullous myringitis is analgesics, as it is a painful condition. First we prescribe analgesics, and because it is an infectious condition, antibiotics are given, topical antibiotics. And to promote healing and prevent perforation, and to promote healing and prevent inflammation, steroid eardrops are also prescribed. Let us now move on to the next disorder of tympanic membrane, and that is, now Myringitis granulosa is an idiopathic condition. What we find in Myringitis granulosa is non-specific patchy granulations. Granulosa, as the name suggests, there are patchy, non-specific granulations, and also there is mucosalized epithelium on the lateral surface. Mucosa is present on the outer surface. Normally mucosa is present as in, we find mucosa on the outer surface of tympanic membrane, that is on the lateral aspect of tympanic membrane. Now this is an idiopathic condition. As the name suggests, Myringitis, it is inflammatory. Now what happens with these granulation tissues and mucosa is, in advanced cases, there will be thickening of tympanic membrane and also some transudate keeps coming out of the granulation tissue. And this transudate will eventually get infected and cause further problems. So, there could be thickening of tympanic membrane and exudation from the granulation tissue. This is about primary granulations which are idiopathic, but Myringitis granulosa can also be secondary to impacted wax or long-standing foreign body, or secondary to an external ear infection, or secondary to otitis externa. The causative factors are tubal dysfunction, where there is negative pressure that is produced in the middle ear, and this can also lead to Myringitis granulosa. So, secondary type of Myringitis granulosa can occur as a result of long-standing foreign body, impacted wax, eustachian tube dysfunction, and otitis externa. Now let us look into the clinical features of Myringitis granulosa. First, there will be otalgia or ear pain. Next, discharge is seen, and what is the type of discharge? It is mucoid and tenacious. And also upon examination we will find granulation tissue. Granulation tissue is found, and this also mostly in the posterior-superior quadrant. Posterior-superior quadrant. Next, let us look into the treatment of Myringitis granulosa. First, we have to do a culture and sensitivity examination of the discharge, and based on that, if at all there is an infection, antibiotic eardrops are started. And for the granulation tissue, cautery is done with silver nitrate. First important part is treatment of infection, if present, with antibiotics. And second important part is treatment of the granulation tissue, and that can be done by cauterization. With silver nitrate. This is about Myringitis granulosa. Now let us look into the last disorder of tympanic membrane, and that is retracted tympanic membrane. This has to be understood in detail as to why retractions occur and what are its consequences. Retraction of the tympanic membrane will occur because of negative pressure inside the middle ear. And how is negative pressure created inside the middle ear? Because of a blocked eustachian tube. Normally, it is the function of the eustachian tube to aerate the middle ear. And if the eustachian tube is blocked for some reason, then slowly the air inside the middle ear is removed, and after a point negative pressure is created, and this negative pressure will suck in the tympanic membrane, which we call as retracted tympanic membrane. So the main reason for a retracted tympanic membrane is negative pressure in the middle ear. And the features of a retracted tympanic membrane are, upon examination, what we find is, first, the membrane becomes dull and lusterless. Normally, the tympanic membrane is shiny and pearly white in color. It has, repeat, upon retraction, it will become dull and lusterless. Second, a cone of light is normally visible, and here the cone of light gets disrupted. Cone of light is disrupted. And it can also be absent sometimes. The handle of malleus is foreshortened. Why does it appear foreshortened? This is the handle of malleus on an intact tympanic membrane, and when the tympanic membrane itself is going inside, the handle appears even more smaller. So the handle of malleus is foreshortened. And the lateral process now is very prominently seen. So prominent lateral process. And we also see that the anterior and posterior malleolar folds have become sickle-shaped. Sickle-shaped anterior and posterior malleolar folds. These are the features of a retracted tympanic membrane. Now, there are various grades of retraction, and these have been given by a scientist known as Sade into 4. There are, repeat, and a scientist named Sade has given 4 grades of retracted tympanic membrane. 4 grades of retracted tympanic membrane, which you must understand. They are very simple in a progressive direction. So, normal tympanic membrane you already know, and in grade 1 what happens is, all the features that I have told above are present. The tympanic membrane is dull, lusterless, cone of light is distorted, handle of malleus is foreshortened, and the malleolar folds are sickled. But the tympanic membrane is not in contact with the long process of incus. It is only touching the malleus. In grade 2, what happens is, all the features of grade 1 are present, plus the tympanic membrane is now in contact with incus or stapes. It has retracted so much inside that now not just the malleus, it is touching the incus or stapes also. And in the next grade, we call this atelectatic retraction. Atelectatic retraction. Here, the tympanic membrane is almost occupying the entire middle ear. It's in contact with the promontory. The tympanic membrane is in contact with promontory. This is an atelectatic retraction. But even until this stage, if you apply pressure from outside on sigillization or on doing Valsalva maneuver, the tympanic membrane will again come back to its normal place. I told you Valsalva maneuver is not just a diagnostic test for eustachian tube function, it is also a therapeutic maneuver, a treatment maneuver for a retracted tympanic membrane. Even until grade 3, a retracted tympanic membrane can be reversed. But in grade 4, it is adhesive. Now the tympanic membrane is completely stuck to whatever structure it is attached to, that is to the promontory. Even upon sigillization, there is no movement of the tympanic membrane. It is an adhesive type of retraction. The tympanic membrane is completely stuck to the promontory, and this is grade 4 type of retraction. Now please look into pictures for better understanding. This first image that you can see here is that of a normal tympanic membrane. And here you can see that the tympanic membrane, a small part is retracted inside, and that this is grade 1 type of retraction. And in the next image you can see that the tympanic membrane is touching the incus and stapes also. It is almost up to the incudostapedial junction, and that is a grade 2 type of retraction according to CET's classification. And here what you can see is also a grade 2, more than the above picture, and if this tympanic membrane is almost extending till here, completely occupying the middle ear, then we call it atelectatic, and if it is stuck to the promontory, that is an adhesive type of retraction. You cannot see grade 3 and grade 4 here, but I hope you can understand with the schematic diagram that I have drawn. The tympanic membrane extends up to the promontory in a grade 3 type. And grade 4 is completely adhesive type of tympanic membrane retraction. So this is about a retracted tympanic membrane. With this, I complete all the disorders of tympanic membrane. First and most important is the tympanic membrane perforation, and then we have and then we have tympanosclerosis, where there are chalky white plaques seen on the tympanic membrane. Then there is bullous myringitis, where bullae or blebs are seen. Myringitis granulosa is about granulation tissue on the tympanic membrane. And we have retracted tympanic membrane with 4 grades of retraction. And also there is the atrophic tympanic membrane, where the middle fibrous layer is missing. So these are all about the disorders of tympanic membrane. Thank you very much.